Oh, really? Well, that's just great. Let me pull up my slide deck for you. Can you see my big PowerPoint thing? Or just give me a nod. Can you see my PowerPoint? Thanks, brother. Okay, good morning, everybody. How y'all doing today? Happy Friday. Hopefully some of the weather sticks with us and we have a good day. We've had a week of core comps. It's been a good time for me. It's great. It's been great to see everybody. It's like a little party again, which is kind of nice. Today is going to be a little different than we normally have done. I kind of want to talk about a crazy case I had. Because like one of the things I always talk to people about is talking about crazy cases and interesting things that have pre-hospital impact are pretty critical to what we do. And so I want to talk about this crazy case. I think it's pretty amazing for us to think about what the implications are. Of course, if there's any clinical updates, I'll bring that up. And of course, Chief Burgess is going to give us any other operational updates that we need for today. Okay, and so that's going to be our big plan today. So one of the hard things that we have at times is really understanding our impact. So many times we miss that greater picture. And I wanted to review an amazing pre-hospital case. And I think it really hits home on the impact that we can have if we get everything and everything is lined up and we are able to intervene. Part of this case is going to be not only our pre-hospital care, but it's also going to be some of the in-hospital care, which goes on with outcome, because I think it just brings the whole story together. So the complaint we're dealing with today is a 62-year-old female presenting with a complaint of weakness. Now, all of us and many of us have different ways to do it, but I think all of us have heard of the sample history, right? And so I'm just going to use that to kind of guide our discussion here. So with this patient, the signs and symptoms that the providers had was that she had right-sided weakness, she's unable to speak and difficulty talking, and her daughter said that she satisfied fast. Okay, we'll talk a little bit about what fast is. So she's satisfied fast and no allergies, medications that like you can see metoprolol and a little bit of Crestor, hypertension, hyperlipidemia. Last time she ate was yesterday. And so the events that led to this is that occurred while eating and then she went to the bathroom. And that kind of set her up for all the problems that she's having right now. So what's fast? So obviously that's our public description of how you think about a stroke. Not the best thing in the world, but not bad at all. We see facial droop, arm weakness, speech difficulty, time to call. And so she had that right facial droop, which we talked about. She had right arm and leg weakness, so hemiplegia really. She had difficulty talking, so she had dysarthria and aphasia. So not only could she have a hard time talking, but she wasn't making much sense. And last but not least, all these symptoms happened 15 minutes before they called EMS. So literally her daughter was able to identify when she was snacking in front of her, then she went to the bathroom, and then she went to check on her. So there was a clear idea of what was going on. So when we think about the pre-hospital care for this, I think we all kind of have an idea of where we're going. Last known well, what's the glucose? What's the pre-hospital screen? Is this actually a stroke or not? What's the LAMS? And whether or not we should activate or not. So let's hit these. So last known well, this is something we have to be pretty specific about, right? So if the patient has a last known normal, which is prior to bedtime, that's last night. That's not now, right? That's a last known well or last known normal that we had that was witnessed. In this case, the EMS providers did a great job. They were able to say, yeah, she said 15 minutes before I called. And so they had a clear idea of exactly what that looks like. What about our glucose? Well, they took the glucose on this lady, it was 140. So that's a good thing, right? So we're always looking for 140s between glucoses, excuse me, between 50 and 400 because that satisfies our TPA region, right? So can we actually give people TPA? The other thing is it identifies for you and I mimics because we know hyperglycemia are a problem. And a lot of times they will present weirdly for strokes and things like that, and also even set you up for more seizures and things like that. So identifying that glucose early becomes really critical. So the next thing is a screen. So the screen was done. So they did our standard laps, right? So Los Angeles pre-hospital screen. And so you start with the 4 screening tests, which are looking at your criteria. Is she greater than 45? Yes. Does she have a history of seizures? No. Does she have symptoms less than 24 hours? I'm sorry. Yes, yes, yes. And at baseline, patient is not in a wheelchair. That's a yes. So all her screens are yes already. So we know that this could be satisfying a stroke. And then her glucose was between 60 to 400. That's another yes. And if we look at her obvious signs, she had a right droop, she had right weak grip, and she had right arm, which is falling quickly. So she's met laps. No questions, he's met laps. So this is a code stroke. We know we're going to have to activate her, right? Well, the next screen we do then is our lambs, right? We got to do our lambs. So when we do our lambs with her, what we find now is her face, she has that droop on the right. Again, her arm, she has flaccid movement on that arm, but her grip strength is a little bit there. So she can feel that grip. You can feel that grip strength, but she can't really move her arm. It doesn't move very well. So in the end, they gave the lamb score a 4. Here you could argue, well, if she's able to do grip strength, maybe it's not flaccid, maybe it doesn't move. So if you could argue for a 3 versus a 4, but the decision here was a 4 because of how dense she was. She was pretty dense, and they said, yeah, this is a 4. So obviously they activated. So here's the report, which I've actually taken off the recording and kind of put the high points here, because let's be honest, sometimes when we give a report, we just kind of go, right? And so here's a report. 62-year-old female presenting with a complaint of right-sided upper extremity and lower extremity weakness and right facial droop. She's having difficulty talking, dysarthria, and aphasia. Last known well was 30 minutes from the scene. So they gave a time specific to when they thought, when the family told them. The lambs was a 4, glucose was 140, 12 leads, normal sinus. I didn't show you that. They had a left 18 gauge IV placed, beautiful. And of note, that was an Anycube, which is awesome. Blood pressure is 160/90, pulses of 110, sats are 100% on room air. We're arriving in 7 minutes. So they called it in, gave a good heads up of what their arrival time was, so everything could be expected. So in the emergency department side of things, there's certain things that nowadays we're classically doing, right? So of course, the classic thing we all know is we're going to do a CT of the head. So we're going to talk a little imaging for a second, okay? So in this first CT head here, this is your common CT non-con. This is what you guys should expect, that once you hit the door, and you say there's somebody with a stroke, the next place they're going to go to is a CT scanner. And at my shop, they show up in the CT scanner. We take people directly to the CT scanner. But here you can actually start seeing some differences. And these are the type of differences we're looking for. They're kind of subtle, but on this side, you see how this is like this gray-white matter is a little different. This is increased hypodensity. See how this area is going out a little further versus this area? That's telling me that there's something going on here. Okay, that could be edema, that could be stroke. It's all the above, right? So that's telling me something's weird. Now, right, generally after the CT non-con, we do what's called a CT angiogram. And the concept of a CT angiogram is shoot contrast, this bright stuff. So here there's no contrast, so you don't see any bright stuff. But see all this bright stuff? That's contrast now, which is in the arteries. And here, right through here, is contrast, which shouldn't be there, okay? And over here, you don't see it as much, right? But this is an artery. This is the left middle cerebral artery. And it's getting bright here because you have a clot through the MCA. You have an obvious clot in the MCA. So really, when all is said and done, what do we want to do with that? We want to open up that clot. We want to end this badness and hopefully get some good outcomes. So what did they do then? Well, they confirmed it. So this is injected. You can actually see the MCA clot, which is the arrow sign. So you see how this is right here. It goes pink. Oops, sorry. Let me go back. You see how it comes right back down there. And so you can see that here, there's supposed to be something here. This is some collateral circulation here, but this is gone, completely gone. So what we were able to do is put something up. So here is the picture of the skull by fluoro. You can see the device coming up here and working its way all the way up into that same spot that I just showed you before, right? And now here you can actually see the guide wire coming up and slipping through that space. Imagine that tickling your brain. And that's worse than an NP swab, I think. I'm gonna have to say. But here is the money thing that we want to see. Look at this. She underwent the mechanical thrombectomy, and look at this rope. It is a rope. I mean, this is the reason this person wasn't able to have any type of function, right? So this is what it's called real, true recanalization. So now you actually have good blood flow, and now you actually are functionally going to be able to do stuff. So the question is, What happens? Well, within 24 hours, her exam improved dramatically, right? So when we started out, she had right facial droop, a global and expressive aphasia with dysarthria, and hemiplegia, upper and lower extremity weakness on that right side. And within 24 hours, she came down to just mild expressive aphasia and right facial droop. When she was evaluated 3 months later, complete resolution, no deficits. Now this is an awesome case. This is the way it should work, right? And the cool part about this whole story for me, as I've looked back at this case, is it comes back to this. It comes back to what we do on the front end, because nothing they could have done would have been able to do what we did initially, which was give them the information to make the decision, right? Because this patient could have easily gone to not a comprehensive center. This could have gone to a small town ED, and what would that have helped us with? Not much. The only way this lady was going to be saved is for us to identify that she needed a thrombectomy. So what were the key things here? Obviously, last known well, so that way we know she satisfies. Obviously, getting that glucose check, getting her screen, getting a LAMS was huge, but of course, activating. So these are the 5 things that whenever you're on a scene for a stroke, hit these hard, and not only hit them hard, document them, write down so that you know it's clear. And then when you do your report, shadow that back. Okay, that's going to be the key aspects of what we need to do when we're doing stroke management. I hope this is a little different. I just love to be able to talk about good things that are happening out there, that there are good outcomes, and they're all driven truthfully by us in a really large sense. It's cool that they have the toys, but they can't use the toys if we don't do our jobs, right? Thanks for that. And so really, I'm not gonna belabor today more than anything else. I think the big thing here is I wanted to point out those things. Any questions, guys, about that case? Pretty straightforward, right? Good. So with that being said, the updates from me, obviously core comps this week, I thought went really well. It was great to see everybody. We're going to have a break for this coming week. And then the following week, we're going to have our second round of core comps on Tuesday, Wednesday, Thursday. If you haven't signed up, you are totally late. So get signed up ASAP. Make sure you're on that list so I don't have to call you afterwards. The other piece here is the protocol is going great. We have another meeting later this month, and next week I'm getting together with our clinical team to just hammer at the protocol and make sure it has all the different pieces. I am proud to say that now that it's up on ResponSoft, I'm pretty sure about 97% of what we have on our protocol is there, 97, 98%. And that just gives you an idea of how similar practice is, but also the other cool thing is a couple of big things that we do have also been integrated, including our team performance CPR stuff. So that's kind of exciting. So you're going to see a lot of things which look really, really similar in the new protocol, which will be exciting. For me, those are the big things. I'm going to pass it over to Chiefs Cochran and Burgess for any updates from them.
Morning, guys. I don't have a whole lot this morning. We've just been, like Dr. Panchal said, we've been involved in core comps, and things are going really well. Everybody's doing a great job. A lot of good stuff going on there. So good job, and get signed up if you haven't been there. So the other thing too is we've got a leadership training meeting will be next Friday at the Bixby campus, and that training will be put on by Captain Farmer and Lieutenant Ransom. So please make sure that you're signed up for that and ready to go. The Kubota now is housed at Station 7. It's down there with a Tahoe, so that way it can be deployed a little faster. That kind of gives us all-terrain vehicles in the kind of the 4 quadrants of the county. Scioto's got one, Tri's got one, BST&G's got one. We have one. The city's got one right in the middle, so that one will be down there, and the Tahoe will be down there with it to allow for quicker deployment, and most likely that's going to go to those runs on the Allen Creek Bike Trail. So I think that's all I have this morning. Does anybody have any questions about anything? Chief Cochran.
I don't have anything other than it's been a great week at Core Comps and some really wonderful conversations about documentation. So thanks to everyone who's gone through all the different scenarios and parts of Core Comps.
You don't often hear, we had a great conversation about documentation. It actually, truthfully, I sat in that room a bunch and it was actually fun. The cool thing for me is we've had a ton of physician coverage too. So there's been a lot of docs around, which has been kind of fun for my residents and stuff. So just a personal thank you from all of you to all of you, because you guys have been so welcoming to them and they've been learning a ton from you. And so thank you so much for allowing them to kind of be part of our family for a little bit there and get some experience. With that being said, guys, that's all I have for you today. Any last questions before we wrap up? Cool. Well, guys, everyone go be safe out there. Oh, I think that's Chief Roboto, Director Roboto.
Your Chief, your phone's not working.
Medic 6 or Medic 7?
Today, Junior.
Chief, we can't hear you. I think I know what you're talking about, though. Maybe I don't, but I think I do. Are you talking about the new trucks you just
If you're on
ordered?
Medic 6, or will you tell them about Medic 6 and Medic 7?
Okay.
Yes.
The trucks?
The purchase.
Yeah.
All
Going
right. All right. Yeah. So 2 trucks just got purchased. So those will be headed to Medic 6 and Medic 7 when they come in. It's going to be a little while. Things are just really backed up on those. They have been ordered. They're ready to go. They're in line to be built. However, due to COVID still and the ability to get supplies and the stuff they need to build those trucks, it's going to take a little while. So I would not anticipate those trucks yet this year. So they are ordered and ready to go. So
Perfect. Yeah, if anybody is doing any type of construction, gotta love the lumber prices right now. Absolutely no clue why. Well, great, guys. Everyone, you guys go out there, have a good day, be safe, and I will see you in 2 weeks, or I will see you next week if you're coming to Core Comps. Thanks again.